The nervous system disorders is actually a really big chapter. We're going to try to go through this as quickly as possible and try to cover some stuff. But it is a big chapter. Please continue doing the quizzes and keep working hard. So, the general effects of neurologic dysfunction. So, first off, you have local or focal effects, which is where there is signs that are related to a particular area of the brain. So the frontal lobe has the function of speech. So if you can't talk, then that means it's something probably going on with the frontal lobe, or maybe going on with the frontal lobe. Or there might be a lesion on the spinal cord at a particular area. So these are very focused, or numbness in this particular part of the body. Examples are paresis and paralysis of the right arm. This could result from a damage of the left frontal lobe. So it's kind of like pinpointing the damage to particular areas in the brain or spinal cord. Expanding lesions will cause impairment to spread from the first area to the adjacent areas, becoming involved. And this could be because of a growing tumor or a hemorrhage in that area that is pushing on and damaging that local area. Then we have what's called supratentorial and infratentorial lesions. And so these are really two divisions between the brain. So if the lesion is above the tentorium cerebelli, that's what it is. So if it's up there in the cerebrum, above that level, it's called a supratentorial lesion. If it's below that level, so it's not in the cerebrum, but below, down towards the brainstem, it's called or below the tentorium, it's called an infratentorial lesion. So these two both have two different kind of symptoms. The supratentorial lesions typically are more the symptoms and signs are of a more discrete area, so it's more specific to a specific part of the body, or it's showing specific numbness or things like that nature. The infratentorial lesions are where it's more widespread because the signals travel through the brainstem to get through all different parts of the brain. So you're going to see more widespread impairment. And it also can cause impairment of the respiratory and circulatory functions because the cardiovascular and respiratory centers are in the brainstem. Also with the infratentorial lesions, you might see a level of consciousness impaired. So the supratentorial are more specific to, this little part of the brain's messed up, so now I can't feel my right hand. The infratentorial lesions are more like spread out throughout the whole body. Also, there can be damage into the right and left hemisphere. If there's damage with left, you may have more loss of logical thinking ability, analytical skills, and other intellectual communication skills damaged. When it's the right side of the right hemisphere, there might be a loss of music appreciation, or sometimes some behavioral problems and spatial orientation and difficulty with self-care. So just a little bit, the right brain and left brain are slightly different, but they do communicate with each other, and so damage to one can damage different functions. The next thing we need to talk about is level of consciousness. Decreased level of consciousness or responsiveness is prevalent in a lot of acute brain disorders. So what we see is it changes. The level of consciousness changes with these acute, very rapid brain disorders. And so with a reduced level of consciousness, we're going to see things like confusion and disorientation, memory loss, unresponsiveness, difficulty in arousal, and loss of consciousness leading to coma, and even can be brain death. There is a scale called Glasgow's Coma scale, and what it does is it adds up. You look at the say there's an injury, and what you're going to do is you're going to look at that person at 700 hours, and then at 900 hours and 1100 hours. So every 2 hours they're looking at this patient, and they're looking to see how their level of consciousness is changing. So you see here they're responding to speech, obeying commands, and then but they're a little confused when their verbal response. And then you can see as time progresses on, they still respond to the eyes opening still responds to speech, but their motor has dropped down, and they have localized pain. And then you can see they are using inappropriate words. So they're not just confused, but they're using inappropriate words. And then at 1100 hours, their eyes aren't open in response to speech. Their motor response is none. They're flaccid, which means they have no motor tone. And then they have verbal response is none. So you see that it's going down over time. So they're going down into a coma. Some particular terminology you have dealing with level of consciousness is the vegetative state, which is where there's a loss of awareness and mental capabilities. This results in diffuse brain damage, so throughout the brain. The brainstem does continue to function in the vegetative state, and you can see that there is a sleep-wake cycle because the brainstem's still working, so it's still doing some things like with respiration and the heart rate, and that sleep-wake cycle. But the person is unresponsive to external stimuli. That's called a vegetative state. Locked-in syndrome is probably the one that's kind of scariest to me. It is where the individual is aware and capable of thinking, but is essentially paralyzed and cannot communicate with the outside world. So that's called locked-in syndrome. Brain death has a certain criteria that must be met to be pronounced brain dead. First is that it's cessation of brain function. So that means that not only the cerebellum, the cortex is not functioning, the brainstem has to be not functioning. So vegetative state is a higher level of consciousness than brain death, because nothing's working in brain death. The electroencephalogram has to be flat and inactive. There can be no reflexes or responses, no reflexes. There can be no spontaneous respirations when the ventilator is withdrawn. The medical professionals have to establish that there's irreversible brain damage by confirmation of the cause. What caused it and why is it irreversible? And then the evaluation has to be performed twice by 2 different physicians. So that's brain death. So you have level of consciousness going down from confusion to a vegetative state, and then eventually it can go all the way as low as brain death. With another common factor of neurological disorders is motor dysfunction. These can happen from damage to the upper motor neurons or the lower motor neurons. The upper ones are going to be more in the brain, the lower ones are in the spinal cord. And what we see with the upper motor neurons, there's interference with the voluntary movements. So we see the weakness or paralysis on the if the damage is on the left side of the brain, the weakness or paralysis is going to be on the right side, so it's contralateral. It's on the opposite side. When it's in the spinal cord, it's going to be due to the lower motor neurons, and it's where the damage is in the spinal cord on the left side, and it's going to be damaged at the left leg. Typically, we see the damage at the weakness or the effects at or below the level of the spinal cord damage. So it's going to be below the spinal cord damage is where the effects are going to take place. With motor dysfunction, there sometimes can be different posturing, decorticate and decerebrate posturing, and these indicate different brain disorders and different damaged areas. So we can see here the decorticate is rigid flexion in the upper and lower limbs. So it's rigid flexion in the upper and lower limbs and extended. The upper limbs are flexed and the lower limbs are extended. So we can see upper is flexed and the lower is extended. This is common in cerebral injuries, or the cerebrum. I'm sorry, in the cerebrum. Decerebrate posturing is where the upper limbs and the lower limbs are extended. Here we go. And we can see that it's going to be more common with brainstem injuries and CNS depression. Okay, so depression of the central nervous system. Sensory deficits, can indicate that there's damage to the somatosensory cortex. This is what processes the sensory information in the parietal lobe of the brain, and it receives and localizes sensory input. It can be mapped by dermatomes. So these are different areas of the skin that correspond to different spinal nerves. So we can see if you can't feel this area of the skin, that means that this spinal nerve could be damaged. The somatosensory can also involve touch, pain, temperature, and position, and involves the special senses, such as vision, hearing, and taste and smell. So you can end up with sensory defects with neurological disorders. Visual loss is called hemianopia, and this is going to depend on where the damage is in the visual pathway. If it's in the optic chiasm, then the vision is lost in both eyes. Partial loss depends on which fibers are actually damaged. If it's in the optic tract or the occipital lobe, the loss of the field is going to be the loss of the visual field is opposite of the damage. So if it's in, let's see if we can see it. I've got an image. Here we go. So you look at the tract. We have the two eyes, right eye and left eye. All right. So the information from the left side coming into the eye comes down and goes to the right side of the brain. And on the right eye, the information from the left side of the eye comes down and goes to the right side of the brain. And then you can see the right field of vision on both join together and go to the left side of the brain. So depending on the damage, you're going to get different loss of visual fields. So if we damage the number one, the right optic nerve, or damage to the right eye, we see that the right is completely damaged. If we damage the optic chiasm, we are completely blind. If we damage the optic tract or the occipital lobe, we can see that if it's on the right side, we see that the left field of vision is damaged in both eyes. So we can partially see out of both eyes. If the left side is damaged, we're going to see only see the vision on we're going to lose the right side of the visual field. But both eyes can still see if it's behind the optic chiasm. That's the key thing to remember, that you can see a little bit with both eyes if we're behind the optic chiasm. There also can be language disorders like aphasia. And aphasia is the inability to comprehend or express language. So you're unable to understand or express. There's receptive, which is where you cannot understand what somebody's saying, but you can talk, and it's damage to the Wernicke's area. And then you can have expressive, which is you have the inability to not be able to, you can't express. So receptive means you can't understand. Expressive means you can't talk. And that's where there's damage to Broca's. Mixed or global means there's damage to both areas and tracts, so you're going to be able to not be able to understand or express. Dysarthria is where the muscles that are used for speech or have dysfunction or are not working fully, and that's called dysarthria. Okay, let's see. Sorry. And we can see the expressive and receptive. So receptive, unable to understand. Expressive, unable to speak fluently. Global is both. Expressive, and here's just a little more detailed information. Expressive is called motor aphasia, inability to speak or write fluently or appropriately. It's usually damage to the Broca's area and the dominant frontal lobe. Receptive or sensory is the inability to understand the written or spoken word and process that information, and it's usually found in Wernicke's area. So we usually see with the receptive, it also affects expression. Okay. Global aphasia is both major brain damage, and we can also see fluent or non-affluent aphasia. Fluent is where the pace of the speech remains normal, so they're still talking, but they're making up words and it doesn't quite make sense. Non-fluent aphasia is where they're having difficulty speaking and can only say a few labored phrases. Okay. Dysarthria is words cannot be articulated clearly, usually due to motor function. Agraphia is where impaired writing ability. Aphasia is impaired reading ability. Agnosia is loss of recognition or association. Moving on to the next general category of neurological issues are seizures or convulsions. Seizures are caused by spontaneous excessive discharge of the neurons in the brain. I always think about like an uncontrollable lightning storm spreading throughout the brain. The causes include things like inflammation or hypoxia, or even a hemorrhage in the brain bleeding. There can be focal ones that only affect a particular site, or they can be generalized and spread throughout the whole entire brain. They're often manifested by involuntary repetitive motions. And seizures can be, through the whole body, or they could just be the eyes flickering, or abnormal sensations that are felt. So seizures can show different signs. Another big one about the brain is intracranial pressure. So there's a lot of disorders that cause increased intracranial pressure, and that's because the brain is encased inside that rigid, non-expandable skull, so it can't expand. So if we increase the fluid levels, or we increase the blood levels, or we increase the cerebral spinal fluid levels, there's nowhere for it to go, so it increases the pressure. Okay, and that increased pressure is going to cause a lot of different problems. One of the primary problems is going to reduce blood flow to the brain. Because the pressure is higher, it's going to be harder for the blood to flow, because blood flows from high pressure to low pressure. Okay, and so the heart pumps it, and it's going to pump it up. If it's pumping against that high pressure in the brain, the less blood flow is going to be able to go through and lead to ischemia and eventually infarction. And it kind of goes down a slippery slope as compensation mechanisms are put in place. So the pressure goes up, and then the heart beats faster, and the pressure keeps going up. The increased cranial pressure, a lot of problems such as brain hemorrhage, trauma, cerebral edema, infections, tumors, abnormal circulation. All those different things can end up with the same increased intracranial pressure and have the same overall signs and symptoms, very similar. Okay, and you can see here's just some different types. You can see there's herniations that can cause pressure to increase, tumors. There's a herniation, different herniations that can increase the pressure. So the signs are pretty similar depending on with all the different disorders. There might be some added to it, but overall you're going to see a decreasing level of consciousness or lethargy. Okay, decreased pupillary responses. That's one of why somebody's hit head. The doctor's going to show that flashlight in the eyes. They're wanting to see pupillary responses. Severe headache, so intracranial headaches, which caused by the stretching of the dura mater and the walls of the large blood vessels. Projectile vomiting, or vomiting that's not associated with food intake, because it's going to stimulate the emetic center of the medulla oblongata. Papilledema, which is going to be the pressure from the brain, for the intracranial cavity down into the back of the eye, and causes the increased pressure causes swelling of the optic disc. So you can see the disc is blown out. That's what they might call it. It's kind of swelling of the optic disc where it's blown. So these are some of the key signs. These are signs that you need to go immediately to the hospital after getting knocked inside of the head, or some kind of trauma. So consciousness, headache, vomiting. You may see increasing blood pressure and increasing pulse pressure. This is going to be compensation for trying to get the blood to the brain, because the brain's going to be low on blood because the pressure goes up, so it's going to try to compensate. And the heart rate may slow because the blood pressure is increasing. Papilledema, which is the eye around the optic disc, and then the pupil becomes fixed and dilated so that it doesn't shrink when you shine a flashlight in it. Okay, so here's your blown optic disc. It should be a nice circular ring, and you can see here it's kind of blown out. Papilledema. Also, you're going to see the vital signs like I was talking about earlier. The vasomotor centers try to respond to the low blood supply to the brain, called Cushing's reflex. So they're going to cause the blood pressure to go up. So we're going to do systemic vasoconstriction. And this is going to try to increase the blood pressure so that more blood goes to the brain to relieve the ischemia. Okay. So also we're going to have the carotid arteries are going to increase have receptors, and that increases the blood pressure, increases the pressure there. And since the pressure is building up so much, it makes the heart rate a little bit slower. Okay. Vital signs continue. The chemoreceptor response is going to be low carbon dioxide levels and a reduction of the respiratory rate. We're going to see improved cerebral circulation. This is temporary because of the increased blood pressure. So if the intracranial pressure does not get resolved, we don't resolve it, then over time, so we increased our blood pressure, we get some blood flow, and that may cause more swelling, more whatever, so the pressure goes up some more. And so we temporarily get rid of the ischemia, and then it comes back, and then it repeats itself. So as the intracranial pressure continues to rise, the blood pressure rises with it, and that increases the intracranial pressure, and then the blood pressure keeps going up. Okay, so it's kind of a cycle that keeps being repeated. And so what we'll see is over time respiration decreases, okay, leading to more ischemia. The pulse goes down because the pressure is going up. And you can see our blood pressure goes up, 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 until it gets to a point where it can't go up anymore, and we're going to have irreversible damage. Some visual signs include pressure on the ocular motor nerve, which is going to affect the pupils, so we're going to look at the pupils. Pupil epsi lateral to the lesion becomes fixed and dilated. So we're going to, if the lesion that's causing the increased pressure is on one side, you may see one pupil that is actually blown. As pressure increases, the shifted contents across the midlines, as the pressure goes up, both pupils become fixed and dilated. Ptosis, which is called droopy eyelid, may occur because of pressure on cranial nerve 3. Okay. Some diagnostic tests that can run for neurological disorders includes computed tomography, CT scans, MRIs, cerebral angiography, Doppler ultrasounds, electroencephalography, which is where you hook up to a brain scan, or your electrodes in your brain, radionuclides, which radioactive materials is put in to track the flow in the CNS, and also a lumbar puncture can remove some CSF, cerebral spinal fluid, and look at it, and also check the pressure inside. So we usually go down between L1 and L2. and remove some cerebral spinal fluid. The spinal cord ends a little bit higher, and only the nerves are going down the middle of the spinal canal. Okay, and they're just drawing out some CSF. Okay, let's stop right here.